Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Today is our 335th episode, and we appreciate you being here. So today I'm actually going to be pulling my topic from a disturbing article I actually read in Part B News, and you can always find them at partbnews.com. But it got me thinking about some of the collaboration agreements between physicians and their QHPs, so their qualified healthcare providers, and their, the physician assistants, the nurse practitioners, clinical nurse specialists. And I found that there's some compliance issues that can actually lose a license for a physician if these are not closely monitored, updated, and understood on what they need to include based on what state you're in. So let's take a look at that, and I'm just going to kind of go over this article because I've read it 3 times, and I just think it's something you need to read or at least be aware of. And I know that my one group that I'm very involved in, the association, the National Society of Healthcare Business Consultants, I know that we tackle the business of medicine. I know that I do a podcast for them as well on the second Tuesday of every month, the NSC HBC Edge. And we have talked about something like this, but it's interesting because as I look at this from a Codecast perspective, I'm concerned for not just my clients, but my listeners that maybe have not taken some of this in agreement. So let me explain what happened and then just kind of talk about what you need to be aware of and understand what is actually a collaborative agreement. So a nurse practitioner and an OB-GYN physician were both fined, and they had to pay fines stemming from their collaborative agreement. And this really was a case warning that these agreements require more attention up front than some practices really may assume. And first, we want to talk about, what exactly is a collaborative agreement? So to get that started, a collaborative practice agreement is a written statement that defines the joint practice of a physician and a qualified healthcare professional, advanced practice nurse, or PA, in a collaborative and complementary working relationship. So it's a mechanism for the legal protection of an APN and sets out the rights and responsibilities for each party that's involved. Now, one thing that you're going to hear on this is the word supervision. This is not the incident to supervision where the physician needs to be in the office, etc. This is a supervision, meaning that the doctor is saying that I'm entering into an agreement with an employee that I am now taking responsibility for everything that they do under their licensure, and this could also affect my licensure. So be aware, these have to be in place in most every state. So coming back to this OB-GYN case, it said in separate actions, the OB-GYN, so the nurse practitioner with the physician, they both have, degrees, agreed to fines of $25,000 and $19,750, which is low, in a California district attorney's office because this case hinged on alleged irregularities with the drafting and enforcement of the pair's collaborative agreement, which is required in California, by the way. And the DA alleged in the complaint against the physician that in 2018, the nurse practitioner presented the physician with an agreement. They actually do name names in the article, but I don't want to do it on here. And it said which the physician skimmed, signed, and returned before going to a different state to practice. Then the nurse practitioner then practiced on the authority of the agreement, including allegedly without the physician's knowledge in her own independent practice as a nurse practitioner. So the complaint reviews the California Medical Board and Nursing Board guidelines, collaborative arrangement, including the NP's permissible scope of practice and methods of review and communication. And it just says that both providers failed to follow them. And so when they were talking about this, one of the things that they found was that while the agreement allowed the nurse practitioner to prescribe, schedule, 3 through 5 controlled substances, the district attorney said it did not specifically identify which controlled substances and medications that the nurse practitioner could prescribe to patients. And that's required in our state, so I can kind of speak to our state. And it said that this nurse practitioner allegedly prescribed anabolic steroids to male patients, and that's the DA said that they had no experience, not just the nurse practitioner, but either did the physician. And remember, you're now responsible for anything that happens when you get into a collaborative agreement. And then it then goes on to say, and this is worse, the DA alleged that the MD spent no time developing the protocols within the collaborative agreement before her supervision of the nurse practitioner began, or at any time during the approximate 2 years that this agreement was in effect. And it also said that the physician also failed to review any physical medical records prepared by the nurse practitioner. And so it's also, here is one of the things that happens. I mean, oh my gosh, I've even seen this in the office that I go to, and I called them out on it and they've stopped doing it. Thank God. They probably don't even want me as a patient anymore. But one of the complaints against this, it focuses on the nurse practitioner, and then I'll quote, holding herself out to the public and to the patients as Dr. blank blank. So while performing medical services and selling medical products as a nurse practitioner, notwithstanding her lack of MD or DO degree and based only on her nursing doctorate, California law specifically prohibits on the grounds that patients of a medical practice are unlikely to make a distinction. And there's also been several lawsuits filed against this. That's why you have to be careful when you say, oh, this is Dr. Sarah, or this is Dr. Sally, or this is Dr. Joe, when they are in effect mid-level providers. And then it says, while the physician's enforcement of the agreement as charged was egregiously careless, again, the doctor said, I just skimmed it. It can be easy for even the more conscientious physicians and nurse practitioners, or PAs, to run afoul of legal requirements. And you need to have these scrutinized and looked at by healthcare physicians. They can remind you that state laws on nurse practitioner and PA collaboration agreements vary widely. So for example, Minnesota, they say that nurse practitioners can practice independently without physician supervision. They can open their own practices and broadly provide primary care services. But in Illinois, the collaborative practice or supervision agreement in place only is for certain tasks, such as prescribing controlled substances. And then again, coming back to California, we are very strict here. And so here we have standardized procedures. We have Title 16 of the Code of Regulations, and it actually spells out what a collaborative relationship should look like, including specifications of NP or PA training, evaluation of competence by supervising physician, and other details that other states may or may not require. In Missouri, for example, that I mentioned, they have a particularly, weird requirement where the physician has to be continuously present on site with the NP for 30 days in certain situations. So even though they kind of have a lax agreement in one area, they don't in another area. And drafting these agreements, oh my gosh, the New York State Education Department for Professions has samples for this, but they also have different names for these agreements. Some call them delegation agreements, some call them the collaborative practice agreement, some call them the supervision agreement. And then the job also gets harder when you try to cross state lines. So for example, let's say you're operating a multi-state telehealth organization, and I've had so many of those come to me. You could be supervising nurse practitioners in 3 or 4 different states. In one state, you may have to review 10% of their charts, meet with the nurse practitioner monthly, be available 24/7 for any questions. And then in another state, you may not have all that. So it just really depends on not only what your state rules are, but what they're calling your collaborative agreement, what the requirement is of the supervising physician, and they have to be in active practice. That was one that I read in Texas, where the physician was just doing administrative work and working for an insurance company and saying that they were now the supervising physician for a PA that was doing certain work, and it was outside the scope of their practice. And so some also under supervision, only some can supervise a certain number, a particular type of providers, and they're limited to how many they can actually supervise. Again, don't think of this as incident two, it's not. Also, when you're looking at your state rules, okay, there's usually information on how you're supposed to communicate. And many states require it to be monthly. Also, they may require review of every note written, or a percentage of note, or a sampling of notes written, and a review of prescriptions written. Typically, the nurse practitioner has to get specific prescriptive authority, meaning what are they prescribing? And every state is different, and you have to submit this paperwork, again, to the states. But here's another thing, and this is what I think was most disturbing to me. When that collaborative or supervisory relationship ends, you have to let the state know, the State Board of Nursing plus your physician board, because if you don't, this mid-level provider could still be listing you as the physician, as their supervising physician. You wouldn't even be aware of it, and they could be treating patients without you realizing that, and that can impact your license. But if you flub any of these elements, you could be, you could catch a charge like that physician did. You could be reported to your medical board. You could be disciplined because a patient complained. And again, and remember, there's lots of issues now of people turning other people in, but we just don't want the physician's license to be taken away when these things could have been avoided. And so complaints often involved the nurse practitioner's or PA's prescription of controlled substances authority, because there's always a concern about safety or diversion. And the nursing board will investigate complaints that a nurse practitioner provided substandard care. And then sometimes it's also sent to the medical board to investigate, well, who is the supervising physician and what did their collaborative agreement actually say? So sometimes they don't actually know who is supervising that nurse practitioner or PA, but they will find out. And just again, lastly, the supervision requirements are not the same as supervision related to billing, the direct, general, or incident two. This has nothing to do with that. This has to do with responsibility for what your provider is saying they are taking for your mid-level providers. And it's completely different, but actually not just more important, but, legally more challenging. So if you want to look up this case, I would Google it. Look up Complaint California versus Anika, Tene Moore, okay, and that's in SLC County and .ca. Then you can also look up Complaint California versus Sarah and Erny, ERNY, that's the name of the nurse practitioner. And if you just want to look and see, let's say you just want to see what one state says about all this, look at my California Code of Regulations, Title 16, Section 1474. You will be shocked. And those of you that aren't in California, just know we're very strict here. And this would be a good place to start if you need to figure out how to get this practice agreement, what you need to talk to your attorneys about. If you have it in-house, remember it's hard if you just have an accountant, they don't really come to these, understandings. You need to get either legal advice on this or a management company that deals with it. You can even go to the New York State Education Department's Office of Professions. Go to www.op.nysed.gov, and you'll see some of those sample collaborative agreements. But make sure that you get advice on this, because I would hate to see it affect any of your providers and the licenses, whether it be the mid-levels or your physicians. And I know I have a lot of coders, billers, managers, administrators listening to the Codecast. This is not something I really talk about because it's compliance. It's not really coding, but it does affect what we do as coders, and it's important to really understand this. The Codecast podcast is also brought to you today by Select Coder. Get all of the decision-making information you need to code in a single online resource. Select Coder offers you the comprehensive coding guidance required to code accurate claims the first time. To learn more about Select Coder, visit codingbooks.com/Select Coder. So there was something else on this that I wanted to bring to your attention. And next week's Top 10 Tuesday, I'm actually going to revisit telehealth. Sorry, but I'm going to do it in a way. I'm going to revisit it as far as what to look for when you're auditing it. I think sometimes we forget that you really need to audit some of these things. So Here's something that came out on the CERT alert, which, those are the statistical audits that Medicare does just based on random sampling and statistics and, how they calculate it. It's kind of similar to me to a RASTAT audit. But the overall improper payment rate for Medicare claims for CERT audits, they did drop less than 1% in a recent review period, according to the 2023, again, this is the Comprehensive Error Rate Testing Report. But the total Part B error rate rose 2%, and that includes over and underpayments. I know you wouldn't think an underpayment would have an error, but it does, because you're forcing them to figure out why you coded incorrectly. Whether you overcode or undercode, it's incorrect codes. What was interesting about this is that there are new players in the party. So we had some new services that have now debuted in the 2023 report, and that was telephone audio only. And the service had a high enough error rate to place them on the reports table of E&M service type of improper payments, and that was on table K1 if you ever look at this. 7.38% of the total error rate of the 8.2 Part B error rate. That's bad. And what the table basically listed, it lists the top 25 E&M codes with error rate ranging from 2 to 61%. But the codes 99442, that's the 11 to 20 minute audio only, and the 99443, that's the 21 to 30 minute. They had the fourth highest error rate and the seventh highest error rate for insufficient documentation, and that accounted more than 70% of those errors. They also had not only insufficient documentation, it said that the reviewer couldn't conclude some of the allowed services were actually provided, or that they were not provided at the level billed, so time must have been missing, or that they were even medically necessary. Some of the things I do in my audits, and I think this is why we get asked to audit externally so much, is we don't just look at coding. We don't just look at CPT and ICD-10. We look at medically necessary. Should this visit have actually happened at all? Also, there was a lot of missing or improper signatures that makes for an incomplete documentation as well. And it says, the documentation didn't show who initiated the phone call. And remember, you can only code for calls initiated by the patient. The treating provider also has to clearly document the time. And one of the biggest problems, and this I saw in most of this because I actually helped audit some of these, a lot of the doctors will say when they code for, let's say, the 99442, they'll say, I spent 11 to 20 minutes with the patient. You can't use range of times. You have to use exactly how much time you spent, because this has to be a replacement for the E&M service, and you have to document why the patient couldn't come in person or be seen audio and video. So that was the update after the PHE ended, and you have to make sure that you understand that responsibility if you're going to report these codes. And I just see too many practices still reporting these codes incorrectly. So just wanted to bring that to your attention. And also, my personal tidbit this week is I'm actually recording from Napa. So my family, so myself, my husband, and my daughter and her husband were here for their second anniversary, an early kind of celebration for my 25th. And so we are here in Napa, and it's beautiful. Luckily we didn't get any rain, and it's just been a really good time so far. So we're headed out for some more wine tasting today. But everyone, make it a great day. Make it a great rest of your week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.